Dear colleagues, today I am presenting the case of a fetus who was carefully studied at our clinic from the second to the third trimester of pregnancy, specifically due to the finding of an anomaly affecting the right kidney. You can observe this abnormality here in these images from the first ultrasound evaluation, which was performed at 20 weeks of amenorrhea. Meanwhile, the left kidney, shown here in the images on the right, appears to be perfectly normal. The main issue in this case was to accurately characterize this alteration, which at first was not clearly interpretable on ultrasound. Essentially, the two main suspicions were a differential diagnosis between a simple renal cyst and focal renal dysplasia. A simple renal cyst is a very rare condition in the prenatal period, but it is a more common renal anomaly in adulthood. It is characterized on ultrasound by an anechoic formation with regular margins, thin walls, and no internal septa, and it appears non-vascularized on color Doppler. The remaining kidney is completely unaffected, and this is usually a unilateral condition. However, the diagnosis is mostly one of exclusion, so it is absolutely essential to carefully assess how the condition evolves over time. Usually, it may gradually decrease in size and even almost completely disappear. It very rarely tends to increase in size, so the prognosis is generally excellent. Partial focal renal dysplasia, meanwhile, is a multicystic dysplastic kidney variant where the dysplastic area affects part of the kidney due to an abnormal interaction between the ureteric bud and metanephric blastema. From an etiological point of view, in most cases, this is a sporadic condition. Very rarely, it may be part of a spectrum of renal malformation syndromes related to alterations in the pathways involved in nephrogenic development. Ultrasound examination in this case usually reveals multiple cysts or clusters of cysts located at one pole of the kidney. The surrounding parenchyma, which is rarely completely unaffected, in the vast majority of cases shows a heterogeneous appearance and an altered interface between the cortical and medullary regions. The contralateral kidney is also carefully and very thoroughly evaluated, as it may sometimes be affected by the exact same abnormality. In this particular case, the prognosis is quite variable. It depends largely on the total extent of the dysplastic area, which may increase or decrease over time, as well as on the amount of unaffected parenchyma and the function of the contralateral kidney. In the specific case under examination, the initial evaluation, which was performed at 20 weeks of amenorrhea, showed a right kidney in which there was indeed an area affected by several cystic formations. These formations were carefully assessed here in terms of their size, with the remaining parenchyma appearing at least partially still dysmorphic and hyperechoic, with an area that instead seemed unaffected. However, given of course the variability of the ultrasound appearance, it was obviously not possible at this point to make a definitive diagnosis. This is a table that summarizes the main characteristics for the differential diagnosis between a simple renal cyst and specifically partial dysplasia. In a simple renal cyst, it is single, whereas in partial dysplasia we mostly see multiple formations. The remaining parenchyma is always unaffected in the simple cyst, but may appear heterogeneous in partial dysplasia. The corticomedullary architecture is preserved in the simple cyst, while it is altered in the dysplastic condition. The contralateral kidney is normal in the case of a simple cyst, whereas in partial dysplasia it must be thoroughly examined and carefully evaluated because it could be involved. Amniotic fluid, which reflects renal function and is therefore normal in a simple cyst, in partial dysplasia depends on the amount of unaffected parenchyma and the function of the contralateral kidney. The progression of a simple cyst usually has a very good prognosis, whereas in cases of partial dysplasia, the situation can gradually change over time. However, both of these conditions must, of course, be carefully monitored with consistent follow-up. In the specific case that is currently under examination, we can clearly see that the bladder is, in fact, normally filled, and the amount of amniotic fluid present was also within the normal limits. Therefore, at this particular time, renal function appeared to be well preserved and was obviously also ensured by the presence of a perfectly normal left kidney. These are the images that were obtained during the second ultrasound check, which was performed at 25 weeks of amenorrhea. The left kidney is, once again confirmed, as we can see here, to be completely normal in terms of its shape, size, anatomical position, and echo structure. Meanwhile, as we will now see in the images of the right kidney, the ultrasound examination findings have changed significantly. In fact, we can observe that compared to the previous check, the right renal parenchyma now appears to be affected by two distinct and separate cystic formations for the most part, with the remaining renal parenchyma appearing to remain largely unaffected. The two distinct cystic formations have also been evaluated, let's say, in the coronal plane scanning view. and here we will also see a detailed dimensional assessment of them. Both structures had maximum dimensions of approximately 10 millimeters in diameter, with a characteristically anechoic appearance, regular margins, no internal septa, and no detectable internal vascularization signals on Doppler imaging. Here as well, the bladder is normally filled and the amount of amniotic fluid is normal. These images, on the other hand, are actually from the most recent ultrasound evaluation, which was performed during the 35th week of amenorrhea in the patient. The left kidney is confirmed to be normal. As you previously saw, the renal pelvis, the size, and the echo structure are all well within normal limits. While over here, we can clearly see how the appearance of the right renal parenchyma has changed even further over time. Indeed, the parenchyma appears to be affected by a single cystic formation with regular margins and an anechoic content, which we can see clearly here in the coronal scan. Below this, there seems to be renal parenchyma that, at least from an ultrasound perspective, appears to be unaffected. The formation has a maximum size of approximately 19 millimeters in total diameter, and so at this point, the most likely diagnosis is that of a simple and benign renal cyst. It was clearly explained to the patient that this is, of course, a diagnosis of exclusion and that a thorough follow-up evaluation in the postnatal period after the child is born is absolutely essential. Here we can see how the underlying renal parenchyma was also carefully evaluated in terms of its size and appeared to be entirely within the expected normal limits for this stage. At this checkup as well, the bladder is normally filled and the amount of amniotic fluid is regular. The peculiarity of this case lies precisely in the fact that it demonstrates how certain renal conditions, unfortunately, cannot be interpreted unequivocally by ultrasound, and above all, how the situation can undergo profound changes during the course of pregnancy. Therefore, in these particular conditions, what is truly fundamental is careful and attentive ultrasound follow-up, with a thorough reassessment every 3 to 4 weeks. The main purpose is to carefully evaluate and closely monitor any changes in the renal ecostructure, to observe the growth and development of the organ, to assess the amount of amniotic fluid present, and ensure normal bladder filling as direct and reliable signs of preserved renal function, to detect the appearance of any new cysts, and, of course, to conduct a careful and detailed study of the contralateral kidney, which in this case had always remained completely unaffected. In this particular case, the key messages to keep in mind are that prenatal diagnosis is not always completely definitive in these types of conditions. However, the isolated and unilateral form generally has a good prognosis, and this is usually true in both conditions, whether it is a simple renal cyst or focal renal dysplasia. What is essential is to carefully plan and recommend postnatal follow-up for the patient, which can then help confirm the most likely diagnostic hypothesis. Thank you very much for your attention.